it's Chris Wallis here from SUO 2023. I'm really pleased to be joined by Dr. Dan Joyce, new faculty at Vanderbilt, and it's really impressive, Dan, to see that you're on the plenary this year in your first year of practice, discussing how we as a community can address issues related to the financial burdens that come with our therapy. So thanks so much for joining me.
Yeah, thanks for asking me, Chris. Appreciate it.
So, maybe let's level set here, just to start with the beginning notions here. What's financial toxicity, and what are we thinking about when we think about these concepts?
Yeah, so financial toxicity is pretty simple, honestly. We know that the cost of cancer care is rising over time, and we know that patients are increasingly required to pay a higher proportion of those costs. And so you can imagine, as costs rise, patients are paying more of those costs. Paying for those treatments can negatively impact the patients. And they can have a toxicity from that cost that's very similar to any other toxicity of treatment. So, chemotherapy can result in neutropenic fever, but also paying for that chemotherapy can result in them taking out a second mortgage on their home, or their family members using life savings in order to pay for that care. And that can have a real impact on their quality of life.
Absolutely. And so, as we try to understand this burden and then maybe try to address it, what sort of research approaches or what kind of data do we need to guide ourselves as a community to make better or more informed choices, taking this into account?
I think the real question comes down to evaluating the values of the patient and what they're willing to pay for their treatments and how they can manage those payments. And unfortunately, a lot of the variables that go into being able to have those discussions with our patients, we currently don't know because people just aren't doing the research to evaluate them. There are very few studies out there evaluating out-of-pocket costs for patients for a lot of the cancer treatments that we have in Oncology. There's even less published on the indirect costs. So these are things like patients having to travel to get their care, paying for parking, maybe even relocating while they receive their radiation treatments. And so we need a more creative way to contextualize, describe, and then convey those outcomes to our patients so that they can make an informed decision upfront and say, okay, this is what it's going to cost me out of my bank account, but this is also what's going to cost me on my life, and then make a decision based on those factors.
And so, how do we take into account in a reasonable way costs and outcomes? We've seen lots of really impressive studies in the last year or two showing, nice Kaplan-Meier curves, and the plenary talk never talks about the, $400,000 a year bill that comes with it. So how do we put these together in some meaningful way that we can counsel patients?
Well, that's the tough part because clinical trials are agnostic. They have no cost associated with them because these treatments are often given at no cost to the patient. So we can't really evaluate how costs are affecting our patients within a clinical trial aspect. But I think what we really need to do is figure out how to have efficient conversations in the clinic with our patients about these costs. And that's where we really have a long way to go. The CMS had a mandate for cost transparency, and what that resulted in was these real-time benefit tools for patients. But what that is that a vendor basically provides a cost estimate for a patient on what it's going to be for them out of pocket, but all of that happens after the treatment decision has been made. So the physician has entered the order for the cancer drug, and then up on the screen in real time pops up the estimated out-of-pocket cost for that patient. But I would say that's too late, and often not even available currently, just because of the many complexities it takes to get that estimate. But I think it would be much more valuable for patients to have that information going into their clinic visit. So if we could somehow say, based on your clinical information, these treatment options may be discussed with you during your clinic visit, and these are what you can expect from an out-of-pocket cost associated with those treatments. And then they can have a conversation with their physician, and they can come together and look at all of the data up front and then decide what's best for them.
So do you think this is something that we're always going to address in a one-on-one patient interaction, or what's the role for physicians to look at bigger health system cost questions? Is there a price of cancer care that's too high?
Yes, and I think that gets to more of a policy discussion rather than a clinician-patient interaction discussion. I think it's difficult in the United States to do that because in the U.S., the freedom of choice is paramount. We value that more than most other things, and so we as Americans don't like a governing body telling us what is worth it and what isn't. And so that's where I think it's challenging to convince the government to change policy based on these value assessments of treatments. But I think we as a community can help encourage it. And one way to do that is to include value assessments in guideline statements. The NCCN has started to do this with their evidence blocks. They've included an affordability category within that evidence block. It's problematic because it's based on expert opinion, and you could imagine when you're asking expert opinion on what the affordability of a treatment option is, they're maybe not always accurate, but it's a step in the right direction. And I think there can be a real push to use more high-quality evidence like a cost-effectiveness analysis to inform our value recommendations within things like the AUA guidelines, which currently are really don't take into account the value of the care that we're recommending.
Absolutely, and I think this is really interesting, particularly in the marginal case examples, right? And so there's great work that came out of where you did fellowship looking, maybe in the adjuvant kidney space, and this may help us inform patient selection, right? Where some patients have, an uncertainty of benefit and a high cost, whereas others have a more certain benefit, and the cost maybe becomes more palatable.
Yeah, and I think that's where cost-effectiveness analyses can really be useful. I think most people, when they see a CEA, they basically throw it in the trash after they see the primary outcome, which is this one was most cost-effective, and that's actually the least important outcome from those studies. Really, the meat of those studies is in the sensitivity analyses, because it's in those analyses that you see, okay, yes, Pembro adjuvant for RCC recommended, but where does the value really hit? Like at what patient's progression risk is it most valuable? And I think those are the kind of studies that really help us contextualize the results of clinical trials in a way that promotes us choosing the highest value option for our patient and not just taking a trial at face value.
So, in our professional organizations or maybe in academia, what do we need to do in the next 5 years to make progress on this front and give our patients the ability to make these more informed, value-based decisions?
I think it really comes down to not allowing us to bury our heads in the sand when it comes to cost. I don't think we have the luxury any longer of saying, I don't understand the healthcare insurance system. I don't know what my patients' out-of-pocket costs are. That's not my job. I think we as clinicians can't say that anymore. We're in an environment with all of these new drugs that are coming on the market with increasing costs. We have a responsibility to the healthcare system, but also to our patients to understand what these costs are, how they're impacting our patients, and then pursue research that's going to make it easier for us to take into account all of those factors when we're recommending treatments and engaging in shared decision making. So it's really just an effort of engagement from all of us, I think.
Absolutely. Well, thank you so much for your time and your insights on this topic.
Thanks so much for having me, Chris. Appreciate it.